Good afternoon, everyone. We're going to go ahead and get started here with our presentation for today's webinar series. I do have a few administrative items, as always, to get us going for our drug-free sport webinar series today on October 18th. So it is required for those of you USC certified athletic trainers looking for continuing education. It is important for you to remain engaged in our live event today, as well as to complete the post-webinar survey that will pop up immediately following this presentation, as well as in the follow-up recording as well. If you have any questions throughout the presentation, please feel free to use the question box provided in the GoToWebinar screen there in your toolbar. We will also provide PDFs of all of our slides in follow-up emails, but it is also available as a handout from today's registration as well. Any other questions about continuing education or this webinar can be directed to myself, Laura Gray, at lgray@drugfreesport.com. A little bit about today's speakers. We've got three excellent speakers joining us from Utah today. Dr. Liz Joy is the Medical Director at Intermountain Healthcare, as well as an adjunct professor for the University of Utah School of Medicine. She's also the President of the American College of Sports Medicine and current President of the Female Athlete Triad Coalition. Carrie Woodruff is a registered dietitian and certified specialist in sports dietetics. She's a sports dietitian for Live Well Center, as well as an assistant professor and lecturer at the University of Utah as well. And then also our final speaker today will be Steve Barachek. And Steve is a licensed clinical social worker, as well as a certified strength and conditioning specialist. Our learning objectives for our certified athletic trainers can be found here. They've also been listed on our registration page, but a number of things, important things that will be discussed today: differentiating between eating disorders and disordered eating behaviors in athletes, identifying evidence-based red flags as signs and symptoms of disordered eating, being able to summarize the approach, impact, and communication channels of each member of the recovery team within the context of the other. So the other disciplines being the physician, medical, the counseling or mental health side, as well as the dietetics and nutrition. And finally, being able to recommend the value and benefit of addressing eating concerns through a multidisciplinary team approach to support athlete recovery. We also have a few poll questions here that just to get a little bit of information on our demographics. So I'm going to launch the first poll. Please take a moment to access this and indicate your current level of practice: high school, collegiate, professional or elite, student or academia. So for those students that may be joining us, or none of these, best indicate your level of practice. So just a few more seconds to get all those votes in. Okay, and I'm going to close that in 3, 2, and 1. So these are our responses. That's about 89% collegiate, 6% high school, 2% for both professional, elite level, as well as other. Okay, so our next poll here. Please select the area that best describes your current scope of practice: nutrition dietetics, psychology counseling, athletic training or team physicians, medical, athletic administration or compliance, or again, other if none of the above represents your current scope of practice. About 10 more seconds to respond. We've got about 82% that have responded so far. And we'll close the poll in 3, 2, and 1. All right, so these are the results of that poll. We've got 68% athletic training or team physician, 11% nutrition dietetics, 9 for athletic administration compliance, and 6 for each of the psychology counseling, as well as 4 other. And we have one more poll question. Please select all that apply, but which disciplines are currently involved in your disordered eating protocols at your organization? So which of the following disciplines are currently involved in decisions on your disordered eating protocols at your organization? And this information is helpful not only for our speakers, but hopefully for all of those listening in as well, just to kind of see a scope of, you know, what's being done at other organizations and identifying areas where we can make some improvements together as well. So I'm going to be closing this in 3, 2, and 1. And share those. You should be able to see these responses here. So quite a lot of spread. Looks like many organizations get many of these disciplines involved. Excellent. With that information kind of out there, I am definitely pleased to begin our presentation. And with our beginning speaker, Dr. Liz Joy, I'm going to pass the controls here to her, and she will get going.
All right, excellent. Laura, I still see the quick poll on the screen. Excellent. All right, now let's see. Okay. All right, well, it's really a great pleasure to join the webinar this afternoon. My name is Liz Joy. As Laura said, I'm the Medical Director for Community Health and Clinical Nutrition at Intermountain Healthcare. And 2 of my volunteer jobs are working as President of the American College of Sports Medicine and of the Female Athlete Triad Coalition. I've been taking care of athletes and community members with disordered eating and eating disorders for more than 20 years in my clinical practice. I served as one of the team physicians at the University of Utah for 15 years and was one of the founding directors of our Student Athlete Wellness Program, which you'll hear more about later today. And really pleased also to have both Carrie and Steve on the webinar with us as well. Both Carrie and Steve serve on our eating disorder team. And just to give you a kind of a brief sense of that before we get started, we have a physician, myself, a nurse practitioner, 6 dietitians, and 8 therapists that care for a cohort of, I don't know, probably somewhere between 300 and 400 patients in the community. And our group meets on a weekly basis to round and care for this population of patients, not all of which are athletes, but many of whom are. And then there's a smaller team that you'll hear more from Steve that is focused on care of the student athletes at the university. So with that as a background, I'll go ahead and kind of get started and maybe just start with this question, you know, why do we care about eating disorders in athletes? And, you know, probably 90%
hey, Liz.
of, yes.
Liz, I'm so sorry, this is Laura, I hate to interrupt, but can you go ahead and share your screen on your dashboard? Just because we can't see your slides quite yet.
Oh, okay.
At the top, it should say show my screen, and you just want to press that play button. There we go. Now we're up.
All right. My apologies. We'll go back to here. Now can you see the sign, the slide that says, why do we care about eating disorders in athletes?
Yep, we're all set. Thank you.
All right. So I was saying that about 90% of the people that we care for are female, but more and more, you know, we're starting to see male athletes struggle with eating disorders as well. And so we'll spend a little bit of time talking about eating disorders in male athletes as well, although most of my remarks will be focused on females. And that's really because of the female athlete triad. And I would suspect most of you on the call are familiar with this term. It was coined back in the late 90s and kind of involves an interrelationship between disordered eating disorders resulting in low energy availability, menstrual dysfunction, and problems with bone health. And what you see in this slide in the upper right-hand corner is health, where an individual has optimal energy availability. They're having regular menstrual periods, which we refer to as eumenorrhea, and they have optimal bone health. And as they move from that upper right-hand corner to the lower left-hand corner, they move through different phases that can adversely impact health. Even a setting of reduced energy availability, with or without disordered eating, health and performance aspects. The same is true for subclinical menstrual disorders, and as well as low bone mineral density that doesn't quite meet the diagnostic criteria for osteoporosis can put a weight-bearing athlete at risk for stress fractures. And then that red triangle, represents, the full female athlete triad, where you have low energy availability, functional hypothalamic amenorrhea, and low bone mineral density for chronological age, oftentimes referred to as osteoporosis. So if we talk about the prevalence of the female athlete triad, there are lots of different studies out there. This one happens to be one that I think provides a pretty full picture of how the triad manifests itself, particularly amongst a college athlete population. This was done by Kathy Beals, who's one of our colleagues at the University of Utah, and Melinda Minor. They surveyed over 400 female college athletes at 7 different institutions. And you can see the rates of self-reported anorexia nervosa and bulimia nervosa. This isn't substantially higher than what we see amongst the general female population of the same age. But when they used a tool called the EDI, or the Eating Disorder Inventory, they found that between 15% and 32% scored at risk for an eating disorder. Nearly a third reported menstrual irregularity, and more than a third reported bone injuries during their collegiate career. So you're looking at a third of university athletes who are meeting criteria for the female athlete triad, which it certainly in my mind makes this rise to the level of a public health concern. If we just talk about kind of eating disorders in general, it's estimated that in the United States alone, 20 million women and 10 million men suffer from a clinically significant eating disorder during their life, and that seems much higher in men than what is often reported, which is 90% female and 10% men. But what we're experiencing is that men and male patients are less likely to present for care for an eating disorder, and oftentimes they're kind of suffering in silence. The risk of premature death is significantly higher in women with anorexia compared to women without, and it's one of the conditions that can result in death in younger females. Part of the reason why we're presenting this webinar today is that earlier diagnosis with evidence-based multidisciplinary intervention correlates with improved outcomes, and not surprisingly, if you have better communication and collaboration between providers, it improves health care, it improves outcomes, and it improves the patient experience. Let's just talk a little bit about eating disorders in male athletes. Male athletes do have a lower prevalence of eating disorders compared to females, but the prevalence is higher than that seen amongst male non-athletes. And similar to what we observe in females, male athletes who participate in sports where leanness confers a competitive advantage are more likely to suffer from an eating disorder than athletes in other sports, and you can see what those kind of observed percentages have been in a number of different studies. And this was a survey that was done amongst more than 700 U.S. male collegiate athletes, and again found that athletes who participate in weight class sports are more likely to engage in pathologic eating and weight control behaviors and to be symptomatic compared to male athletes in endurance or ball game sports. So eating disorders are considered a psychiatric disease with other medical consequences. And there are strict diagnostic criteria that are used to make that diagnosis. And it's published in something called the DSM, or Diagnostic Statistical Manual, and we're up to version 5 right now, this being the most recent. And with this most recent version of DSM, they did make some changes to the diagnostic criteria for eating disorders. There were no changes to anorexia nervosa or bulimia, and anorexia can present as either a pure restricting type or a binge eating purging type. Binge eating disorder was added to the DSM, and they replaced eating disorder not otherwise specified, or EDNOS, with 4 distinct conditions, one being called atypical anorexia nervosa, so somebody who meets some of the criteria for anorexia but not all of it, a purging disorder without binging, night eating syndrome, so somebody who wakes up in the middle of the night and eats, and then something called avoidant restrictive intake disorder, which I guess another way of putting that is the quote-unquote profoundly picky eater who doesn't necessarily have body image disturbance or fat phobia or over-concern about body size, shape, and weight, but has very limited dietary intake for a variety of reasons. I want to make you guys aware of a tool that you can access quite easily on the web. This is a tool that Carrie, Steve, and I were all involved in the development of. It's called the Eating Disorder Care Process Model. This is an educational tool that was developed and aimed at healthcare providers, and especially primary care providers, on the management of eating disorders. And given our time limitations, I'm not going to go through this with any detail, although we'll be referencing some of the material in this care process model. And if you simply Google Intermountain Healthcare Eating Disorder Care Process Model, you will see that it shows up second on this Google search. And it's freely available on the web, and we've gotten some really great feedback on this tool in terms of supporting the development of good programs aimed at identification and treatment of people with eating disorders. I did want to just kind of give you a sense of the DSM-5 criteria. I know that this slide is, the writing on this is very small. It will be a little bit easier to read when you get your handouts, and of course when you access the care process model on the web, you can pull up these diagnostic criteria for the various eating disorder conditions. I did want to try and distinguish DSM-5 diagnostic criteria and eating disorders from kind of disordered eating, and it sounds somewhat simplistic, in terms of distinguishing eating disorders from disordered eating, but it really starts with kind of this idea that they don't quite meet the diagnostic criteria for an eating disorder. So, as clinicians, we go through this list. I don't have to look at it anymore, just because I spend so much of my time taking care of this population. But if they don't meet these diagnostic criteria, they may kind of fit into that disordered eating bucket, in contrast to meeting the diagnostic criteria. There are also people who just have kind of misconceptions about, what healthy eating is, to support their health and their sport. They may be just not eating enough calories, to support the amount of activity they're doing. The athlete who's doing 2-a-days, training upwards of 4 to 5 hours a day, and is eating, I don't know, for a gal, maybe 2,800 calories, which, may seem like a lot of food, but in actuality, they really need to be eating over 3,000 calories in order to support that level of activity. And then, I also put in there the lazy eater, and this is, somebody who, oftentimes ends up in my office, and it starts, skipping breakfast because they can't get out of bed in the morning. And they don't pack a lunch the night before, and they certainly don't have time to pack a lunch, before they leave for school in the morning. And they don't necessarily want to spend money at the cafeteria, or they don't like the food in the cafeteria, so they grab a Diet Coke and a bag of Fritos, and that's lunch. And then maybe they come home and they have a quick snack after school, and then have dinner with their family. And they eat whatever mom or dad cooks. That's kind of the example of the lazy eater. And but if they're an athlete and they're a quote-unquote lazy eater, then they just may not be meeting their energy requirements and may end up with low energy availability, leading to other health consequences. And then I think the fourth group, and I'll let Carrie kind of expand on this in her comments as well, is the chronic dieter. And I have seen this many times in athletes, where you've got somebody who is always trying to manage their dietary intake and try and perfect their body size, shape, and weight for their sport. And oftentimes these are athletes who tend to be on the heavier side compared to their athlete peers. So it's the long-distance runner who has a BMI of 21 when everyone else on her team has a BMI of 18, or the gymnast, who, is always concerned that, she weighs too much compared to other girls on her team, even though she's got great power and form and is performing well. But these are examples, from my experience of the athletes with disordered eating in contrast to those who meet diagnostic criteria for eating disorders. I also wanted to bring your attention to an article that was published earlier this year in the British Journal of Sports Medicine. It was an update on eating disorders in athletes, authored by myself and 2 other physicians from UCLA. And this, I think this is an open access article. I did put the reference at the bottom of the slide, and I have a PDF of this as well, and maybe I can upload that later as well for you to be able to access at the end of this webinar. But it has a lot of really great information in it. It's really written for a broad clinician audience, whether you're a physician, an athletic trainer, a dietitian, or a mental health professional. If you're an athletic director or in compliance, this might be something you want to pass along to your athlete care teams for review. So I'm going to talk a little bit more about the female athlete triad. Again, since this is the predominant group that you're going to see, or kind of health consequences related to eating disorders or disordered eating. And these risk factors are very well understood and supported by the medical literature. And they include a first menstrual period after age 15, infrequent menstrual periods defined as less than 9 periods per year, a low body mass index, less than 18.5 kilograms per meter squared. And I just thought I'd give you some examples of kind of what that looks like for various height individuals. I'm oftentimes hear that people are surprised to hear that somebody who's 5'6" and weighs less than 115 pounds may have a lower BMI than is healthy. Obviously, people with disordered eating or an eating disorder that we've talked about, in terms of both restrictive eating and binge purge behaviors, but also excessive training. So people who are doing more exercise than is recommended based on their coach or their training requirements. Other risk factors include, particularly when we're talking about low bone mineral density, a positive family history of osteoporosis, a positive family history of eating disorders is another risk. I always get a little bit in trouble for saying vegetarianism because I certainly know plenty of people who are very healthy vegetarians, but I can tell you that the literature would suggest that amongst adolescents who choose to become vegetarian, that they have higher rates of subsequent anorexia. So they kind of jokingly refer to it as the gateway drug to anorexia nervosa. So people who tell me they're vegetarian, as a clinician, I want to know why, and keep a close eye to make sure that they're meeting their both their energy needs and their macronutrient needs. People with a history of low calcium intake, so those people who are lactose intolerant, may not be making very many calcium deposits in their bone bank, and they can be at risk for low bone mineral density. Low vitamin D is, pretty endemic, particularly in more northern climates where we're covered up, because vitamin D production is dependent on kind of sunlight on skin. And so, in places like Utah, it's pretty cold. It's, I think, only about 50 degrees today. So I've got a big long sweater and long pants on, and if I were outside even for a walk, I probably wouldn't have enough sun on my skin to make adequate levels of vitamin D. So low vitamin D can be a risk. Prior stress fractures, certainly a risk, since prior injury is the most significant predictor of future injury. And then coexisting personality factors like perfectionism, in addition to other mental health disorders like anxiety and obsessive compulsive disorder, can be a risk for the triad. In terms of screening, these are the questions that we recommend from the Female Athlete Triad Coalition website. And again, ask questions that address low energy availability, menstrual function, and bone health. So have you ever had a menstrual period? How old were you when you had your first menstrual period? When was your most recent period? How many have you had in the past 12 months? Are you currently taking any female hormones? Do you worry about your weight? Are you trying, or has anyone recommended that you gain or lose weight? Are you on a special diet, or do you avoid certain types of foods or food groups? Have you ever had an eating disorder or a stress fracture, or been told you have low bone mineral density? So many of those questions are covered on the pre-participation physical evaluation. This is a part of a monograph that's been developed by a number of sports medicine organizations, and really for our high school and collegiate athletes, optimal screening for the triad does occur during that pre-participation exam. And this is an example of some of the questions on the form that address eating disorders in the female athlete triad, and they're quite similar to the ones from the Female Athlete Triad Coalition website. So what are some red flags that you should look for in regard to eating disorders amongst athletes? And these are things that I've heard and learned from athletic trainers who are traveling with athletes on the road, from parents. These are things that we talk about in our rounds, and our behaviors that we try and ascertain from individuals with whom we're treating. Probably the first and foremost is kind of an over-concern with body size, shape, and weight. And these may be individuals who are constantly talking about, their fat thighs or their fat stomach, or I don't like my arms, or my butt is too big. And, they exhibit lots of concerns about, in a very focused way, about their body size, shape, and weight. Skipping meals is certainly a red flag, as is cutting out food groups. And, again, vegetarianism is the gateway drug to anorexia. But now, not only are people, in the past they cut out fat and then they start cutting out, red meat, and then they cut out gluten, and then they, next thing you know, they're down to, fruits and vegetables and water. And it's pretty hard to meet your energy needs and your macronutrient needs when you're eating fruits, vegetables, and drinking water. Weighing themselves frequently. So, if you're an athletic trainer and you see somebody who comes into the training room and gets on the scale every single day, maybe even before and after practice, observed weight loss, certainly would be a red flag, particularly amongst somebody who doesn't have a need for weight loss. In terms of people with maybe binge purge behavior, food that kind of disappears, and I've heard from athletes who are roommates that I have concerns about Susie because all the food in our apartment is gone, and because she might be binging and eating other people's food. Or parents tell me that they bought a whole bunch of groceries and they come down in the morning and much of the food that they purchased has disappeared. Likewise, from parents, we hear about food wrappers in the bedroom. So oftentimes binging is done in secret, and people don't want to be observed eating an entire box of cookies or 2 bags of chips or an entire half gallon of ice cream. And it oftentimes happens at night. And so parents will find evidence of this in the bedroom. So food wrappers in the bedroom is another red flag for binging. Going to the bathroom immediately after meals can be a red flag for purging behavior, whether typically in the form of self-induced vomiting, and then in athletes and even non-athletes, but would be excessive exercise, above and beyond what is recommended for training. And in our non-athletes, we sometimes, hear about people who go and run on the treadmill for 30 minutes after every meal. And amongst athletes, they're going through a 2-hour workout and then going for a run. Or, the athlete who rides her bike an hour to campus, goes to class all day, goes to practice, and then rides her bike an hour home. So lots of energy expended during active transportation. But those are all red flags that you should be looking for. In terms of treatment, it's really kind of generally starts around this whole concept of low energy availability, and you'll hear more about that from Carrie. But amongst athletes with disordered eating or an eating disorder, we do focus on multidisciplinary team treatment with a physician, a dietitian, and a mental health professional. And in our athlete population, it also includes the athletic trainer. They are the eyes and ears, of the athlete care team, and oftentimes have the closest relationship with the athlete. So we're incredibly indebted to their work with the athlete to help identify people who may be at risk, as well as to support the treatment recommendations. I think Steve may talk a little bit more about the role of the strength and conditioning specialist. We have that on the student-athlete wellness team at the University of Utah. They have a very unique relationship with the athlete that's very different from the head coach. And in a collegiate setting, I would encourage you to include them as part of your care team. And parent role, in a lot of times, coaches can play a role, but oftentimes, well, that's a little unfair to say, but sometimes, the coach can be the cause of the problem. And so, we hope that through education and mutual respect, that, coaches can really be a part of the solution and not be a part of the problem in athletes who are affected by disordered eating disorders of the triad. And in athletes who have low energy availability but no evidence of disordered eating, so they kind of fall into the lazy eater category, maybe the chronic dieter, the dietitian, obviously plays a critical role. As a physician, my role is, first and foremost to assess their function, and their ability to kind of attend to their day-to-day activities of daily living, which, in a student athlete means get up, get dressed, go to class, do their homework, go to practice, compete, do all of that. And if their dietary restriction and other health consequences don't allow them to do that, then we need to make some changes. Obviously, I take a history and perform a physical exam, including an evaluation of their mental health, and oftentimes we draw laboratory studies to further evaluate health consequences. And that helps me really to make a diagnosis. Do they have an eating disorder? They meet diagnostic criteria, or do they have disordered eating? I make a diagnosis in regard to their menstrual status and with their bone health. And in terms of bone health, we're oftentimes using something called a DEXA scan, or dual energy. Oh my God, I can't remember what DEXA stands for. But anyways, a DEXA scan helps us measure bone mineral density. And then lastly, all of this kind of, informs clinical decision making in regard to medication use, the level of care, referrals, and then ultimately clearance and return to play. I did want to mention that there are a number of co-occurring psychiatric and medical conditions. I kind of alluded to that, co-occurring or comorbid psychiatric conditions are not at all uncommon, particularly mood disturbance like depression, anxiety, obsessive-compulsive disorder. In people who are struggling with bulimia, they have higher incidence of substance use disorder as well, and particularly alcohol, and personality disorders like perfectionism put people at risk. There are a number of common medical comorbidities and consequences of eating disorders. IBS is irritable bowel syndrome, and that's kind of a bit of a garbage term. I think it's any bowel symptoms that make you irritable by and large. But, when I see particularly teenagers, who come to see me with irritable bowel syndrome, oftentimes looking to see if they have underlying mental health problems and or eating disorders. GERD is gastroesophageal reflux disease, and not surprisingly that people who binge and purge, particularly people who are purging through self-induced vomiting on a regular basis, are at greater risk of also having gastroesophageal reflux disease, which can be very uncomfortable. Nonspecific abdominal pain, very common amongst anxious adolescents. People with multiple food allergies or intolerances. Recurrent sore throats and poor dentition, which can be a consequence of self-induced vomiting. Fainting and palpitations, can be a consequence of dietary restriction, purging, any number of eating disordered behaviors. Likewise with fatigue, and we've talked that amenorrhea is a consequence of low energy availability, and low bone mineral density is a consequence of low estrogen, which occurs in the setting of menstrual dysfunction. In terms of medication management, there's really no eating disorder be gone pill. Recently a medicine called Vyvanse was approved for the treatment of binge eating disorder, approved by the FDA. And fluoxetine or Prozac does have an indication for the use of in patients with bulimia nervosa, but they're certainly not curative. And you don't, give somebody, Prozac and voila, they stop their eating disorder. And the same thing is true with Vyvanse for binge eating disorder. But we do use psychotropic medications oftentimes to treat kind of those comorbid mood disturbance, such as depression, anxiety, obsessive-compulsive disorder, and there's a lot of different cocktails that are used with varying degrees of efficacy. We use a number of gastrointestinal medications, some to kind of promote motility in people who have chronic constipation as a result of restricted dietary intake, and we also can treat some symptoms of gastroesophageal reflux in people who have a lot of purging. And then oftentimes I get guidance from the dietitian as to other dietary supplements that may be necessary based on their dietary restrictions. But certainly multivitamins, calcium are not uncommon, sometimes iron in somebody who ends up with anemia. And zinc is sometimes used to stimulate appetite in people who are zinc deficient. I did want to just show you stratified into low, moderate, and high risk, and there's a point value assigned to each one of those. So for example, an individual who has some dietary restriction currently or has a history of disordered eating under low EA would get a score of 1. If that same person had menarche at 15 years and 2 months, they get another score of 1 there. If their BMI was between 17.5 and 18.5, they get a 1. So you can kind of see where that goes. So we add up all those points and then determine where do they fit on this risk stratification. So for someone who has 0 to 1 point, they're considered to be at low risk, and they would get full clearance. Somebody who gets between 2 and 5 points would be considered at moderate risk, and they would get provisional or limited clearance. And somebody who has 6 or more points would be considered at high risk, and they may be restricted from training and or competition. And what does that mean? So somebody with provisional clearance, this is somebody who is in recovery, or they have had in the past problems with the female athlete triad and may thought to be at persistent risk. And so training and competition is based on their compliance and follow-through, oftentimes with their written contract. Whereas limited clearance may be for somebody who isn't quite there yet in terms of their recovery and their health. And so they may have some limitations placed on their training and competition as specified in a contract, with the goal being that they would get to full clearance. And then somebody who is restricted isn't restricted in perpetuity, but the goal is that, with comprehensive care, that their clearance can be revised and upgraded as the healthcare team determines that they are reaching stated health goals. And I just want to draw your attention to this article that was published also in the British Journal of Sport Medicine back in 2014. It was the Female Athlete Triad Coalition Consensus Statement on Treatment and Return to Play of the Female Athlete Triad. It's an incredibly comprehensive document. It includes all the information that I just provided in regard to clearance and return to play. And what I'm showing here on the screen is an example of the contract that was actually initially developed at the University of Utah under the auspices of the Student Athlete Wellness Team, and then revised for this publication. So I think this would be very useful. So with that, I'm going to turn it over to Carrie Woodruff to talk about the role of the dietitian.
Hi. So Liz, you can go ahead and thank you. So when I first meet with an athlete, I always do a general assessment. And while this is not a comprehensive list of all the questions that I ask, here's some really important components that I want to collect when I meet with them. So I get basic anthropometric information in their age, their height, their weight. I do get body composition when available, and we do have a BIA, a bioelectrical impedance analysis machine that lets us do an initial assessment of body composition, and we can decide upon further discussion if we want a more precise measurement, such as a bod pod. But to get an idea of what their body composition is, I ask questions on medications, dietary and herbal supplements. And with medications, I do ask about birth control use, because when we look at menstrual function, maybe an athlete indicates it's a female athlete, that they are menstruating, but then if we find out that they are on oral contraceptives, which is that may give a false indication that they have healthy mental functioning. So that's an important component. I look at their injury history. So do they have a history of repeated stress fractures? I do a 24-hour dietary recall where I specifically and explicitly ask them to tell me everything that they eat on a day-to-day basis. And here's where I get what Dr. Joy mentioned. I can get an idea of that sort of chronic dieter. So even if this isn't someone who does have a diagnosed eating disorder, I get an idea, are they on a low-carb diet or a low-fat diet, or are they on a high-protein type diet? Now, some of this needs to be misinformed, or it may not be deemed to be a risk factor or even unhealthy per se, but just getting an idea, do they avoid grains, or do they avoid treats and sweets? Do they avoid dairy products for various reasons? And so it's really important for me in this 24-hour recall to tease out, are they always eating, for example, Special K compared to something like shredded wheat? Nothing wrong with Special K, but are they always consuming the lower calorie varieties of certain types of foods? And so this is where I can get an idea of their dietary habits and any sort of tendencies towards disordered eating. And here is where I'll also ask questions about, are they tracking their intake? Are they counting calories on a daily basis? Again, just trying to get an idea of what their approach is when it comes to food and how they are, what their balance is with their intake. And then I assess their training schedule, because as Dr. Joy mentioned, an athlete could be consuming 2,800 calories, but if they're training 4 to 5 hours a day, that's probably going to be inadequate for what their dietary needs are. So I get an idea of how often are they training, for how long, and the intensity of their training. Okay, Liz, you can go ahead and switch. So here's something that I just want to show a screenshot of, and this comes from the Female Athlete Triad Coalition, which is available on the internet, and this is how I assess for energy availability. And Dr. Joy introduced the concept of energy availability, and really what this is it is the, you take the amount of energy that someone consumes, so you estimate how many calories they're consuming on a daily basis. You subtract out calories that are expended with exercise, estimating their energy expenditure, and you figure out what this value is relative to their kilograms of fat-free body mass. And so, but this is a lovely calculator here that's available through the Female Athlete Triad Coalition that helps you to assess their energy availability. And it walks you through sort of estimating body composition if you don't have it, how to estimate their energy expenditure. And so it's, of course, just considered an estimate of their energy availability, but it helps give us an idea of what is their energy availability. Now, 45 calories per kilogram of fat-free body mass is considered to be ideal, and less than 30 calories per kilogram of fat-free body mass is considered to be low energy availability. And in between is sort of a gray area. So when we work with athletes, so typically we see menstrual dysfunction starting at, most likely with 30 calories per kilogram of fat-free body mass or lower, but sometimes even in that 30 to 40 range, and typically in the high 30s entering into the 40 calories per kilogram of fat-free body mass is where we're going to see healthier menstrual functioning and adequate energy available for optimal bone health, for example, and other health outcomes. So this is just a great resource to assess overall energy availability. And then on this next slide, this just shows how I assess what their energy needs are. It's just an Excel spreadsheet. So there you see the definitions. But on the next sheet, you see how I get a baseline idea of what their energy needs are based upon an activity factor. For dietitians, I use a Harris-Benedict, and I do the Cunningham equation if I do have body composition as well. And I use the different equations to get sort of a baseline. And then through monitoring of weight and energy and how their training is, we can kind of fine-tune if their energy intake is indeed optimal. But this is how I assess basic energy calories as well as carbohydrate and protein needs. So this is all part of my dietary assessment. And then you can go ahead and change slides. So for my role as the dietitian, what I see my role as being is to educate athletes on the importance of nutrition. And while we know that for those first few bullet points of energy activities such as living, cognitive, emotional health, immune health, bone health are important for all individuals, the benefit we have of working with athletes is that they may or may not be motivated by those components. They're typically motivated by performance. And so when we can put food in the context of improving performance, then that's a lot of times we can get that buy-in or increased motivation to improve their dietary behaviors. And I always try and put our nutrition recommendations and frame it so that they are seeing the connection between what we're recommending and how that can positively impact their performance. And, you know, I have on the bottom there, food is medicine. So I actually had a patient come to me who was working with Steve as a therapist, and she is an elite level athlete. He said, you know what, Steve put in the concept to me of saying that food is medicine. And so if I had cancer, I would undergo chemotherapy. Well, just as importantly, if I have an eating disorder, I have to see food as medicine. And so sometimes just seeing it in that analogous way of, you know, food is what is actually going to help them to improve and to get better and to get healthier and help them to perform better is just something that may resonate with them to improve their dietary intake. And then finally, you know, looking at how what my role is in context of working with the team it's very important that I continue to communicate with both the physician and the therapist. So when I'm fortunate enough to work in the same clinic as Dr. Joy, though historically that hasn't always been the case, but we do meet regularly regardless to make sure that we're on the same page when we look at weight goals. What is the individual's goal weight, which has to be individualized. You know, we look at what is I consider to be a biologically appropriate weight. That doesn't necessarily mean a BMI of 18.5 or higher. I currently have a patient whose goal weight is actually a BMI of 20.2 and higher because of her high muscle mass. And so for her threshold is a higher weight. So we have to look at what is a goal weight, and using other inputs such as body composition and other biochemical measures help us to establish that goal weight. The physician can help assist with lab work, and typically, you know, Dr. will order labs that I have access to so I can identify nutrient deficiencies, lab work related to bone density through the DEXA scan. We'll look at resting energy expenditure to see if there's maybe a blunted metabolism related to restricted dietary intake. Looking at exercise recommendations, when a patient asks me, am I clear for exercise? That's the advantage of working with a physician or other medical providers to say, well, you know, based upon my knowledge, your intake seems adequate to support exercise, but it is your medical provider who can guide that decision as well because of their, because of all the additional information that they're collecting. And then just looking at behaviors. So we're always communicating about behaviors. We recently had a patient who was reporting very different information to me about her restricted intake compared to what she was reporting to the physician. And this is communication between the therapist, the medical provider, and myself that is all equally important because we all tend to hear different things. And so when we can share what we're hearing, it helps us to make sure that we are basing our guidelines and recommendations on the most accurate information. And in regards to my collaboration with the therapist, you know, I always try and support their work. If, for example, the therapist gives me a heads up, the patient's doing heavy trauma work, I may back off being more aggressive with my dietary recommendations. And so we can work in conjunction with each other to make sure that we're supporting each other's work. Conversely, I can let a therapist know if I'm really pushing a patient nutrition-wise, and so they can support that in their work with the patient as well. Oftentimes I'll go to the therapist and say, hey, I'm really stuck with this patient because of behaviors, because of eating disorder thoughts and other challenges, and so do you have any recommendations for me? And they always have some really great insight for me. I always communicate what we're working on, as we've addressed, and then again, just behavior. So it's making sure that we are all on the same page with what we are aware of regarding the athlete's behaviors. Thank you.
Thanks, Carrie. This is Laura with Drug Free Sport. Just due to our limited time and with Steve's agreement, we're actually going to go ahead and take some questions. And so we can actually address the psychology aspect of the multidisciplinary care through hopefully your questions here as well. And so Steve will weigh in with his expertise on how these matters impact as well. So I'm going to transition to our first question. And for those of you still listening, please feel free to use that question bar to submit additional questions for our speakers in our final few minutes here. First question is, when looking at premature death in women, what is the average life expectancy for a woman suffering from anorexia nervosa? And so any of our speakers who are able to address that, potentially Liz or Carrie.
This is Liz. You know, I don't know what the average lifespan is for an individual with anorexia. I don't even know that I've seen that data. But we do know that people who have anorexia nervosa, particularly women, are more likely to die from consequences of starvation and suicide compared to women who are not affected by anorexia nervosa. And what is meant by kind of complications of malnutrition, it generally results in cardiac complications and fatal arrhythmias.
Great, thank you. Second question here, what are some suggestions when coaches ask to see the weights of their team members? And how would a program address that situation?
Well, I guess I'll comment on that first. And, you know, we have had situations at the University of Utah where coaches were weighing athletes, where they were doing body composition testing on athletes and then listing it by the person's name on a bulletin board. And there's a lot of reasons why they can't do that anymore. You know, HIPAA is one of them, and you know, that's considered protected health information, and you can't make that public. So HIPAA has helped a little bit with things like that. You know, that doesn't mean that a coach can't weigh an athlete or ask an athletic trainer to weigh an athlete. But certainly what we have done is work very closely with our athletic director, other members of the athletic administration, as well as with regular educational seminars to the coaches to talk about how weighing them and talking to them about their body size, shape, and weight you know, can be detrimental and result in disordered eating or eating disorder behavior. And if they have specific concerns about the athlete's weight and how it may affect, you know, safety or performance, that they should reach out to a member of the athlete care team so that we can devise a healthy, safe program so that athlete can reach an optimal body composition.
Great. Our final question here, can you share the way that you describe communication between the different providers to the athlete, and what kind of release form that you've used in the past to share information between the multidisciplinary team?
Steve, do you want to address that from the student athlete care team perspective? He may still be muted, but I'll answer while we're waiting for him. But we created a release form with the general counsel at the University of Utah, at least for our student athlete population, that the athletes signed, you know, during their kind of preseason orientation. I think they, at least, you know, when I was a full-time team physician, they signed it once for the entire 4 years, but now they may sign it every single year, I think. And essentially, it gives permission to the care team that's caring for those individuals to openly kind of discuss health concerns amongst them as a way to try and develop cohesive and comprehensive approaches to caring for them. So we have a legal, release form that they sign, and again, it allows that conversation to take place between team physicians, athletic trainers, dietitians, and mental health professionals.
Steve, I don't know if you had some comment there, but we are, if you've got a kind of quick response to that or anything to add, free to do so.
I think Liz answered that perfectly, and I know we're out of time. So if anybody has questions, I'll be happy to respond by email.
Excellent. Yes, and I can, if you do have questions, I know I did provide my email earlier in the presentation. I'd be happy to pass those along to our speakers, and they can get back to you directly. It's lgray@drugfreesport.com. We also have another upcoming webinar on November 9th covering mental health and collegiate athletics. And so we do look forward to hosting you here. We apologize for any sound quality issues during the presentation today, but do want to thank all of our speakers for taking the time out of your day to present on this important subject. And thank you all for attending. Please do stay tuned for that post-webinar survey that should pop up, or if you don't have time to complete it today, it will be in the follow-up attendee email that should arrive within a 1 week's time period. Thank you so much, and everybody have a terrific day.